So, as you know, this lecture is a tribute to the memory of Browning Hoffman. Browning was a psychiatrist that joined our faculty in 1971, held joint appointments in the schools of medicine and law, true joint appointments. These were not paper appointments. I mean, he was both places all the time. He founded the Institute of Law, Psychiatry, and Public Policy and laid the groundwork for other programs in law and medicine more generally at the university that I think we now take for granted. He did all this with extraordinary energy and creativity until his work was cut tragically short by a sudden death in 1979. The period of his work, roughly the 1970s, was a time of rich intellectual ferment in both the domains of policy and practice that generally go or merge at the intersection of law and psychiatry, and the allied specialties, subspecialties within psychology also. First of all, a rich body of mental health law that protects the rights and interests of people with mental disabilities. And secondly, the body of rules that govern the use of mental health evidence in courts, especially in criminal adjudication. And of course, that kind of testimony is offered by a variety of forensic mental health specialists, including forensic psychiatrists, forensic psychologists, and forensic social workers. This excitement of that period spawned a new generation of scholars working at the intersection of law and behavioral sciences generally. And among the new generation at that time were Browning, myself, my colleague John Monahan, who is here as well, and 9 of the previous Hoffman lecturers, all of whom are listed on your program brochure. This year's Hoffman Lecture will be delivered by Dr. Marc Lewis, but before formally introducing him, I want to say a few more words about Browning. He had a passion for ideas and truly awesome intellectual energy on literally hundreds, and that's not an exaggeration, of occasions over the 5 years that we worked together. He would come into my office and plump down in an easy chair, saying, "I need to rattle your cage." And off he would go into the latest effort to solve what might have appeared to everyone else to be an intractable problem. He was a man with a mission. Genuine collaboration across the disciplines of law and psychiatry and other behavioral sciences, and he viewed his own assignment here at the university as one of building bridges to allow that to happen, which is harder than it might seem. His immediate aim was to connect the training and professional activity of lawyers, psychiatrists, and psychologists in a common cause: better informed public policies and improved administration of the law. The fundamental challenge, as he saw it, is putting all those professions in the same classroom at the same time. He had a clear vision of the possibilities for such joint educational activities, and he put many of them in place here at the university within a few years. They include the Forensic Psychiatry Clinic, a practicing clinic at the medical school that continues its work, postgraduate fellowships in each of the pertinent disciplines, law, psychiatry, and psychology, and a training and continuing education portfolio for professionals in law and mental health disciplines already in practice. He also planted the seeds for a partnership between the university and state government in Richmond that has helped to shape mental health policies in the Commonwealth for 4 decades. For me and all his friends and colleagues, Browning's death was made especially tragic by a sense of promise unfulfilled, as you can imagine. Yet Browning himself had a different view. He told me at his bedside in the hospital that he had felt that he had already accomplished most of what he set out to do. Now, I have no doubt that imminent mortality had scaled down his ambitions a bit, but he did, in fact, accomplish a remarkable amount in his 8 years here. He left an enduring legacy for which hundreds of students and residents in the schools of law, medicine, and medicine owe him a great debt. The fellows and junior faculty whom Browning personally trained in our program in that short period of time, now serve on faculties of law, psychiatry, psychology, and public health throughout the country and are among the leaders of this field. I have been emphasizing Browning's contributions to law and psychiatry, but his creative vision and intellectual curiosity ranged across the lifespan and touched all of what I will call the sciences of human well-being. We could just as easily have entitled this lecture series the Hoffman Lecture in Law and Human Behavior, or the Hoffman Lecture in Law and Medicine. Over the past decades, in fact, the topics addressed by our distinguished lecturers have ranged from ethical issues at the end of life to psychiatric genetics. Our most recent lectures in the last couple of lectures have focused more on contemporary social issues. Dr. Lawrence Steinberg explored the implications of recent advances in the science of adolescent development to criminal punishment. Professor Jeffrey Swanson in the last lecture explored the connections between mental illness and gun violence, obviously issues that continue to be pertinent everyday public discourse. So today, we continue in that vein by taking on the science of addiction at a time when our nation is struggling with an epidemic of opioid addiction of unprecedented scope and magnitude. Mark Lewis will address a question that is once technical and provocative. Is addiction a brain disease? And does it matter? He asks whether addiction is a brain disease and why the answer matters. Even the technical part of his subject is interesting. What does it mean to characterize a condition as a disease? What risk factors for premature mortality or morbidity, such as elevated blood sugar, does the person have a disease? What does it mean to characterize that condition as a disease? Does it matter if the elevated risk can be reduced by changing one's diet and behavior? Is being overweight a disease? Ingesting addictive drugs changes the brain, not only during the acute phase of intoxication, of course, but in more enduring ways. And those changes can have harmful effects on behavior and well-being. Does that mean addiction is a brain disease? Chronic alcohol use clearly can cause organic injury to the brain, and it is commonplace to characterize these effects as brain pathology. But does the experience of craving drugs, a cardinal diagnostic feature of addiction, amount to a manifestation of brain pathology? Obviously, the words that we use to characterize addiction carry huge ethical implications for individual choice and also for public policy. Indeed, there is a case pending in the Massachusetts Supreme Judicial Court right now involving a woman who had committed drug offenses and I think theft in relation to those offenses, who was convicted of them, obviously had an addiction problem, agreed to participate in drug treatment as a condition of probation, and then, not long after the order, relapsed and was then, her probation was revoked. And the argument being made is that addiction, based on diagnostic criteria and many of the articles recently written in this vein, that addiction is a brain disease and her relapse is a symptom of the disease. So how can she be punished for relapsing when essentially it was expected? Virtually the entire public health leadership of the United States characterizes addiction as a brain disease. Does it make scientific and conceptual sense to use these words? And whatever the answer to that question, is it socially or clinically useful to use them, as our public health leaders appear to believe? Even the word addiction itself is provocative. I have been engaged in drug policy discourse for nearly 50 years. The word addiction has been in and out of favor over that period of time among different stakeholder constituencies. Many think it should be avoided because it is stigmatizing and pejorative. Others think a weaker term, such as the current diagnostic statement of drug use disorder or characterization label, understates the severity of the condition. The grip of addiction, so to speak, is a bit more emphatic than drug use disorder. And that use of the term addiction signals the imperative importance of doing something about it, at least from a societal standpoint. Once the selection committee for the Hoffman Lecture had decided to devote it this year to the topic of addiction, I spent many hours exploring what has become a vibrant and very timely multidisciplinary conversation about the language of addiction. One of our previous Hoffman lecturers, Stephen Morse, a member of the Pennsylvania Law faculty, has been a prominent participant in that discussion and one strongly opposed to the use of characterization of addiction as a brain disease. I can tell you without a hint of flattery or hyperbole that I was strongly drawn to Marc Lewis's insightful and careful analysis of this problem, particularly because it effectively weaves together developmental neuroscience, clinical psychology, and behavioral economics. Marc graduated from the University of California at Berkeley in 1975, having majored in music. That was the year, by the way, that the National Institute on Drug Abuse was established and launched what has been an extraordinarily fruitful investment in the neuroscience of addiction. Whatever you call it, this has been an extraordinary body of work and has been extremely influential. After more than a decade of travel and occasional graduate studies, and generally, shall we say, delayed maturation, Marc earned his doctorate in applied psychology at the University of Toronto in 1989. He immediately launched a distinguished scientific career in child development research, focusing on neural mechanisms of self-regulation in the developing brain. In 2010, after approximately 20 years at Toronto, he decided to take a different path, moving to the Netherlands, joining the faculty at Radboud University, and refocusing his scholarly attention on how an understanding of developmental neuroscience can inform the study of addiction, which, after all, typically has its roots in adolescence. Marc's first book on addiction, Memoirs of an Addicted Brain, in 2011, connects his own years of drug use with an account of how the brain changes with addiction. In the second, The Biology of Desire, Why Addiction is Not a Disease, in 2015, he links biographies of addicts with neuropsychological findings to show how addiction develops and how it can be overcome. Both books have been published in several languages, and Biology received the PROS, Association of American Publishers, Award for Psychology in 2016. It is indeed with great pleasure that I present Professor Marc Lewis to deliver the 17th Hoffman Memorial Lecture in Law and Psychiatry.
Thank you, Richard. That was a very informative and uplifting introduction. I feel a bit like I've walked into the lion's den here, being in the U.S., because, as you say, it's pretty much the hegemony. It's the main act that addiction is a disease. It's handed down by all of the authorities, governmental, mental health, the NIH, the NIDA, and everybody else, that addiction is indeed a disease. And many of my talks are in Europe, Australia. I've gone back to Australia a few times, Canada, and other places. I've been to the U.S. a bit and talked in the U.S., but really, yeah, this is kind of like, I feel that there's a certain amount of resistance that I can expect towards my arguments. But I will try to convince you that the disease model of addiction is not particularly sound in its logic and its rationality, and also in terms of its public utility, it is at best ambiguous. It has some advantages, but certainly some disadvantages as well. And as Richard suggested in his introduction, I'm certainly not wanting to throw the brain out with the bathwater. I have studied neuroscience myself and done a bit of research on publication, well, more than a bit, for much of my career. And I very much respect the brain science that has come about through the efforts of NIDA and the other addiction authorities at work in the US, not to mention the funding available for research elsewhere. Okay, so the main tenets of the definition as laid down by NIDA, the National Institute on Drug Abuse, and this is available on their homepage. Addiction is defined as a chronic relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful consequences, and the emphasis here, chronic and relapsing brain disease, obviously. Brain imaging studies from drug-addicted individuals show physical changes in areas of the brain that are critical for judgment, decision-making, learning and memory, and behavior control. Emphasis on physical changes in the brain, and of course these functions are pretty much all of the functions that we care about, judgment, decision-making. In other words, it pretty much messes up the entire brain. And third, in vulnerable individuals, the disease of addiction is produced by chronic administration of the drugs themselves. So it's the drugs that are messing up the brain. They're wrecking the circuitry. And that's been their position for a long time. That's the party line, although I do think it is changing. I think it's changing, and there is some kind of resolution, maybe I'll get to that at the end, between different perspectives on addiction and where we might be able to go with that. So, premises of the disease model. First, brain change equals brain disease? No. Oh, that synchronizes better on my Apple. Oh well. Because, of course, the brain is supposed to change. I mean, your liver and your heart and your lungs you want them to stay pretty much the same from early in life until death, but your brain is supposed to change. It's designed to change. We know that brain change is absolutely necessary for all learning, for all experience, for all activity. And neuroplasticity has become a very, I think, increasingly popular way of thinking about brain function. Neuroplasticity, the idea that brain change isn't something that just stops when people achieve adulthood, but rather is a capacity that the brain has throughout life. And we see this in its most dramatic form in recovery from strokes and other forms of brain damage. It's a very plastic, changeable organ. So maybe the kinds of changes that drugs make in the brain, maybe that's the problem. No, because we see very similar brain changes in the behavioral addictions. Gambling, porn addiction, sex addiction, gaming addiction, internet addiction, binge eating disorders, obesity. These are sometimes called process addictions, behavioral addictions, and there's been a lot of work lately showing that not only do these things look like substance addiction in terms of their behavioral manifestations, but very, very much the same in terms of their neural manifestations. In terms of the whole dopamine circuitry, the dopamine coming up from the midbrain to the striatum, changes in cellular mechanisms and patterns in the striatum, shutdown of certain prefrontal functions, and all that stuff. And in fact, Neurovolko has studied binge eating disorders for years and talked about some of the correspondences with substance addiction. So no, it's not drugs per se that's the problem. Maybe brain change in addiction, maybe it's addiction. Maybe that's where the disease idea comes in, because the brain changes that occur with addiction are unique. But I don't think they are. And I think this is actually a critical part of the argument. Okay, just follow my slides. Brain changes seen in addiction, for example, changes in sensitivity of the dopamine receptors, are seen with sports, wealth acquisition, politics, shopping, love and sex, religious experience. They're shown in all kinds of human activities that have to do with highly motivating activities, highly motivating rewards, attractive things like getting money, getting sex, getting pizza, getting God, and also with repetitive acquisition, so repetitive patterns of acquisition. When you put those two things together, high motivation and repetition, you in fact get changes in the dopamine system. Dopamine is all about drive. It's all about goal relatedness, goal focused. It focuses and narrows your attention, and it gives you that motivational push towards the goal. So it has an emotional component and also a cognitive component. And it is a very human reaction to rewards, to goals that we find attractive. I think the love and sex story is in fact the most interesting, because falling in love is like an addiction behaviorally in some fairly obvious ways. And we see the loved object as being entirely delightful and the best thing in the world, and that lasts for a while. And then we start to see some of the perhaps more negative aspects of the relationship, which become more clear over time. And hopefully we get past that and keep going, but not always. And indeed, there's a lot of studies about the dopamine and sexual response in mating, whether it's in humans or in prairie voles. It's part of the deal. Premise that addiction is chronic. No. There's lots of evidence to show that most people recover from addiction. And that goes with all drugs, including heroin. Most people recover. This may seem counterintuitive, but it's there. You can Google NESARC for some of the main findings, and there's quite been a number of newer studies that show people recovery rates from a number of drugs, methamphetamine, heroin, certainly with alcohol. Alcohol is a great example because alcohol use disorder or binge drinking, for example, in college is fairly common, but people who have that, and it's a real addiction, stop in their 30s, usually in their early 30s. Most of them stop because they're growing up and because their life is changing and there are different responsibilities and a different sense of self. So these would be the sorts of contextual factors that would get people to quit. And they quit without formal treatment. The majority of those who quit without treatment, and that's a really important fact. They call it spontaneous recovery or maturing out of addiction, phrases of that sort. There is a percentage, clearly, maybe 10, maybe 15, I don't know, it varies with the substance and the situation and the country and the culture and the economics and everything else, but there's a certain percentage that do need treatment, but most don't. And most diseases get worse with time if they're not treated, at least serious diseases. So there's a seeming contradiction. And fifth, the idea that addiction destroys the will. This has been touted by Nora Volkow, the head of NIDA, really consistently for years now in her lectures and podcasts and so forth, and writings, that the problem with addiction is that it takes away willpower or the capacity to make choices. That's what it does. And that's why we can't blame addicts for the things that they do, because they lose the capacity to choose. And I'll talk more about that in a few minutes. I would argue that no, addiction does not destroy the will. As someone who myself was in addiction, an addict, if you like, during my 20s, I remember how much willpower was required just to acquire drugs, to get them, forging prescriptions and cheating and lying and stealing and all the rest of that awful stuff that addicts do because of the obstructions that they face. It takes a certain amount of cognitive coherence, clarity, and a lot of determination in order to keep going. But then it's also what we require to quit. And I also want to mention that free will is a dodgy concept at best. We don't really understand free will. It's very difficult to understand what that is from a scientific perspective. We know from experiments in neuroscience and cognitive science that people make choices without having any idea what they're choosing, without being conscious of their choices. Their brains can predict what they're doing before, like 300 milliseconds before they actually choose whether to press the right button or the left button in studies. But in a more pedestrian way of speaking about it, we don't know what, we make hundreds, thousands of choices during the day, which are just almost unconscious, if not entirely unconscious. The things that affect them are mood, previous choices, conditioning, associations, emotional state, fatigue. What determines whether you go through an orange light or stop? Can you say what determines that choice? You just do it. You just do one or the other, and then you think about it. And that's the case not only with more trivial decisions. I don't know. In the Netherlands, that's not so trivial, but here it may be. But it's also the case, I think, with rather important decisions. We might think about whether or not to raise a certain topic of discussion at the dinner table or with our teenage offspring or whatever it is, or with our partners. Which might lead to all kinds of consequences. And think about, should I do it, should I not do it? This is going to have a big impact one way or another. And we might decide, no, I'm not going to bring it up. It's going to be too messy. And then suddenly you do it, just like that. Those are the kinds of choices in which immediate gains are weighed against long-term consequences, which we think people make in a voluntary, logical way with this organ of choice. But in fact, that's not how we do it. We do it spontaneously. And I think that's similar with drug use. as I said, willpower is not only very handy for getting drugs, it's also very handy for quitting drugs. In fact, I think it is absolutely, and I think anyone who's worked with addicts or been in addiction themselves knows this. It's that determination to quit. You might be sick of it, you might be disgusted with your own habit, and so on and so forth. You might have learned to hate it in all kinds of ways and recognized how harmful it is. But it takes determination and willpower to resist the urge, to resist the cravings, and you have to keep that up for some period of time, and then you're done with it. Or else you're not done with it for good, maybe just for a while. But over a period of time, as I say, most people do quit and stay quit. Effort, determination, willpower. I don't know what the difference is. So I disagree with that premise. So here's the problem. You get this dichotomy, and this is the big deal in the US right now. It's either a disease or it's a choice. And of course, this dichotomy has come along and partly out of very good intentions, not wanting addicts to be stigmatized and mistreated and punished and secluded and abandoned because they're evil people or they're self-indulgent or weak and or character flawed, but rather because they have a disease. Well, obviously that's a noble intent. Yeah, but then the reason these people are not looking too miserable is because they're not being stigmatized, and yet the state of not having a choice is obviously not optimal. I wouldn't like to not have a choice about doing irrational, harmful, self-destructive things on a regular basis. I would much rather have a choice. So is this dichotomy necessary? Is it helpful? And what do we do about it? Okay, so in other words, what do we say to the addict who comes for help, who comes for treatment? You have a chronic disease that you will never be free of. You have lost all control, and therefore you can't be blamed for your actions. People won't stigmatize you for being immoral, but they will stigmatize you as someone with a mental illness, forever different from normal people. Well, this is not small potatoes. It's been a topic in and out of public discourse for decades, partly the anti-psychiatry movement and all the rest of it. But we know, both from anecdotal and from research evidence, that people who are identified as having a mental illness experience all kinds of stigma. I mean, if you're sitting down in a restaurant and there's someone over there with a mental illness, and you'd probably rather sit at the other end of the restaurant, even if there's an open window nearby and it's the middle of winter. It's because it's built in. The mental illness is built in. It's a part of your character. This is an essentialist notion that you can't get rid of it. And this extends past the bounds of the addiction debate to all kinds of issues in psychiatry, which of course I won't get into in detail. But whether depression should be seen as an illness, even our approach in the West to psychosis and schizophrenia is not necessarily the only approach. In some cultures, psychotic episodes are not considered to be manifestations of a disease at all, but rather are considered to be cyclical changes in the way that you experience reality, which, left alone or respected or provided with useful forms of social support, actually go through some period of time and then go away, often for years before they recur. So having a mental illness, the idea of mental diversity in terms of disease versus normality has got all kinds of problems built into it. And then we say to this poor person, because you have a disease, you must seek treatment from medical authorities, even though doctors don't actually know how to treat addiction. Now, I should be clear. I like doctors a lot. My brother's a doctor. My father was a doctor. Doctors certainly have their place in the treatment of addiction. But the question is, do they have the tools to understand and fight the psychological processes that work in addiction, or is their role different? And if their role is different, it may have to do only with things that people are addicted to that create chemical dependencies, obviously opioids being the prime example. Yes, you get a chemical dependency, you get withdrawal symptoms, and you get all kinds of nastiness, which makes the issue of quitting all that much more complicated and difficult and actually rather horrific. And doctors obviously have a place there. But most addictive drugs do not create chemical dependencies. You can take methamphetamine, crystal meth, for 15 years and stop and have no withdrawal effects. I mean, you might be pretty tired for a few days. Same with cocaine, same with crack, same with all kinds of things. Same with alcohol use. If it's heavy but moderate, unless you take large quantities of alcohol, there's not much of a withdrawal period. So this is a very specific, subcategory of addictions for which medical treatment may be required. But as far as the psychology of addiction, doctors aren't trained in that. They're not trained to be psychologists. They've got enough to do. So, in my books and my talks, my articles, what I try to do is to understand how people become addicted. As Richard explained, I come from developmental psychology. I see things in terms of development, in terms of developmental change from childhood to adolescence through the lifespan. And so I see addiction in terms of a developmental pathway which has particular stages to it. And I want to understand how people become addicted, these are my books, and how they grow beyond addiction. And I thought I'd read this just because I get hundreds, maybe thousands of emails like this. And I'm not trying to boast, but I'll just read it to you. Just bought The Biology of Desire, and on first chapter, the first few pages, it brought tears to my eyes and had me yelling out loud, yes, yes, in recognition. As a recovering addict, your book has given me more hope for my future than 3.5 years of therapy and 12-step meetings. I am told I have a chronic brain disease and my addiction is constantly waiting in the wings. My only hope to attend 12-step groups, pray, and confess my shortcomings to God. If I disagree, well, that is my addict, and often they call it my addict brain, tricking me with denial and rationalization. The solution: I must attend a weekend intensive, come to more sessions, buy another workbook, more 12-step meetings, 90 meetings in 90 days. I often feel shamed and condescended to by the very people who are telling me that shame is at the root of my addiction. People who only have a hammer and see all of my challenges as nails. People who I often feel are only a hair healthier than me, this idea of health. Many of their judgments seem rooted in subjective morality, not science. I mean, this is obviously a self-selecting sample of people who send me emails, but I do talk to an awful lot of addicts who really hate the disease label in all kinds of ways, and also the fusion between the disease label as it comes to us from medical and addiction authorities in the US and the 12-step movement. The 12-step movement, I'm sure you know, it's been around for a long time, most of the 20th century, and there's been this kind of unholy marriage between the 12 steps and the idea of addiction as a fundamental, essential disease. The idea being with the 12-step is that you have a character flaw or an allergy or something about yourself which is never going to go away. It's never going to change, and therefore you have to spend the rest of your life attempting to control it. And for a lot of people who've come through addiction, that's not how they feel, and that's not what they want to be told. For one thing, they want to move on. I'm not an addict that has to control my impulses. I'm not that interested anymore. I don't like it anymore. I don't think about it anymore. People talk about that all the time. So I think we need to be very cognizant of that, of those voices. As I say, I've talked with thousands of people who've lived through addiction. But I am still very interested in their brains, and this is maybe something that is a little bit different from other people who might oppose the disease model. So briefly, the contributions of the American NIH authorities, funding bodies, and so forth, and policy organizations, the research, progress in specifying neural changes underlying addiction, which are mainly sensitization of the nervous system to particular cues, particular stimuli, blunting, giving way to blunting, which is a kind of capping off of the level of enjoyment which you can feel in relation to other rewards, but also even in relation to the thing that you happen to be addicted to. Motivation by contextual cues, the way cues can chain together to lead to an addictive response and all that stuff. Conditioning and automatic compulsive behaviors. This is a big deal. And people in addiction science often talk about the shift between impulsive responding, which you get in early stages of addiction, which is, I want it, to the later stages of addiction when you just do it. You don't think about it. It's no longer motivated by reinforcement. It's no longer motivated by an expectation that this will be nice. It's just something you have to do, like in OCD. Okay, and all of these things are explained by changes in dopamine circuitry. Dopamine comes up from the midbrain, goes to the striatum, which is the kind of motivational center of the brain, which has different components and parts that basically execute behavioral sequences in different ways. It's got a southern pole, which is in charge of impulsive behavior, the ventral striatum, and it's got a northern region, the dorsal striatum, which is in charge of automatic Pavlovian behavior. And you actually see changes in the way dopamine interacts with these systems, changes in the circuitry, of course, because all active synapses will affect changes in synaptic networks, and also the changes in the relation between the striatum and the prefrontal cortex, obviously the seat of our capacity to steer and to make judgments and think about the future. So that's all really good stuff, and let's not throw the baby out with the bathwater. Let's not throw the brain out with the bathwater. I think that we need to pay a lot of attention to these neural changes, but I don't see them in terms of pathology. I see them in terms of developmental progression. So what I would like to see is for experts to combine neural findings with other forms of data. So we've got the neural findings, changes in dopamine circuitry, reduction in prefrontal activation, the neurobiology of stimulus response, that automatic behavioral response that I mentioned. Look at that stuff, but also use developmental psychology. Study normative stages. As Richard said, addiction starts in adolescence. That's very significant. And look at individual pathways. What kinds of events predict particular futures? Look at risk and resilience. Look at risk and protective factors. These are all things that developmental psychologists have been working on for many decades. And that's a really important part of the picture. And it doesn't jive that well with the disease theory of addiction. And third, lived experience. You know, the people who the people who crunch numbers, looking at fMRI images and crunch numbers and so forth, and come out with findings about brain changes in addiction, many of them have never met an addict, a real addict, or certainly have not talked with them about what it's like. And that's not their fault. They're very busy doing the things that neuroscientists do. But there's a huge amount of information available from subjective accounts, from memoirs. Addiction memoirs are great reading, by the way. Well, there's mine, which of course is great reading. But there's many others, and they're fascinating, dramatic, epic stories, which very often end with people getting out of addiction. Not always, but often. There's a lot of data there, and I think that these three pillars of knowledge need to be combined to really get down and understand what addiction's all about. Okay, so instead of a brain disease, I would think of addiction as a habit of thinking, feeling, and acting that develops in response to social and emotional challenges. So I'm just going to spend about 10 minutes giving you a kind of a taste or a flavor of a learning model of addiction, which is different from a disease model of addiction. That diagram, I've used it in a lot of classes, is supposed to indicate the many, many paths, developmental paths, leading from birth to death, I guess, or whatever. And what I often emphasize is the choice points, the branchings in the path. I mean, we can all look back on our lives and identify points at which we could have gone one way or could have gone another way. I can identify exactly when I got into bad drugs, when I went from a repressive boarding school in New England to Berkeley, California in 1968. It was like, okay, this is for me. But there were other choices and other paths and other places I could have ended up. And there were many other choice points on the way. And I think it's really useful to analyze what happens at these choice points and what kind of factors influence developmental trajectories. not just whether or not you become addicted to something, it's the kind of thing you become addicted to, whether you develop a narrow social organization or group that supports that addiction or works against it, whether you get treated with abuse and stigmatization and punishment on the one hand versus care and connection on the other hand, all affect the branchings in the developmental pathway. So, speaking of development, let's start at the beginning. The ACE scores, this is a large survey, several waves of survey research, at least, I'm not sure, lots and lots of participants. I think it was 17,000, but I can't remember. And the ACE stands for Adverse Childhood Experiences. And just to cut to the chase, so we're talking now about abuse, which could be physical, emotional, or sexual. We're talking about neglect, parental divorce, which doesn't have to be aversive, but it can be, maternal depression, having a parent in prison, parental alcoholism. There's about 10 of these factors. And the more you have in your childhood or adolescence, the greater your chances are of becoming an alcoholic or an injected drug user. Okay, these are undisputed facts, and the comorbidity, so to speak, between PTSD and addiction is huge, so somewhere around 80%. All of these things, we could say they leave in their wake some form of PTSD or depression or anxiety, which are all really very often overlapping categories. So, there's a developmental precursor for you, or a set of developmental precursors. So what happens then? This is my little cartoon we know a lot about learning. We know about operant conditioning, we know about Pavlovian conditioning, we know about the use of inhibitory mechanisms and planning and sequencing and rule use and all of these factors in learning. Psychologists study all this stuff. And we know about the neural correlates, the neural manifestations of most of these forms of learning as well. What we often don't think about or don't study is the cyclical nature of learning. So there are particular kinds of learning that involve, as I say, repeated exposure, repeated action, repeated doing, which means repeated stimuli, repeated responses, and so on and so forth. And those are the kinds of behaviors that are going to build in neural changes much more deeply in a much more entrenched, ongoing fashion than things that we indulge in on a more occasional basis. I think that's pretty obvious. But what is this kind of cyclical pattern? What drives it? What's the actual sort of chemistry of it? Chemistry in a metaphorical sense. Think about wanting and getting. I mean, if you want pizza, you're going to think about, the different places where you might be able to order it, or you might be able to drive out and get it. And the more you think about the different pizzas and the different varieties, the more you want it. The more you want it, the more you think about different ways of getting it, and so on and so forth. So there's a little feedback cycle just built in to the middle of it. And then eventually you go out and you get the thing that you want, whether it's pizza, or whether it's sex, or whether it's heroin, or whether it's a college education, or what, I suppose, and things that can be satisfying for a shorter or longer period of time. And that wanting is driven by emotional needs of one kind or another. Obviously, otherwise you wouldn't be wanting. And the problem is that the various solutions that we have for our desires and our needs are temporary in one way or another, or they lead to different kinds of outcomes or futures. And with addiction, the problem is that the rewards, the satisfaction of the desire, the craving, the satisfaction of the need is so very temporary. And whether you're for cocaine, it's about 15 minutes. For gambling, it could be the 3 or 4 hours that you spend at the casino. For heroin, it's about 6 or 7 hours, for et cetera, you know what I'm saying? But after that, you feel like shit because you've engaged in something that has gone away completely and left you with nothing. And it's also something you weren't supposed to do, and it was going to leave you in a worse state than you started. And you feel besides the loss of the thing itself, you also feel some shame or self-recrimination about having gone out and done it in the first place. So what you're doing is you're increasing the emotional need that drives the feedback cycle. And that's what that's what George Koob calls the dark side of addiction, although he confuses that with withdrawal symptoms, in my opinion. Okay, so That's why addiction is a self-perpetuating, self-reinforcing process. Well, so are some other things like language learning and maybe, becoming an athlete. I mean, there's certain things that we keep doing because they're reinforcing and they get us to do it again, and then we get very good at it. We get very skilled. We develop a very particular set of skills. And believe me, addicts have a very particular set of skills. But the problem is that they're being driven not only by the satisfaction of the need or the desire, but also by the loss that they've encountered through this extremely ephemeral reinforcement. And that's why being an addict isn't fun. It's not fun at all. So, here's a little, psychologists love boxes and arrows. Here's a little learning model that might explain addiction from a developmental perspective. You've got the trigger or the cue, which could be a phone number, a half a pill on the bathroom floor. It could be passing the liquor store on your way home from work. It could be a phone call from a buddy, whatever it is, anything, which leads to craving, which is a state of emotional wanting, desire, which leads to imagining, thinking about ways to get it or to do it, which leads to, which increases the salience of the desire, the salience of the cues. The cues are psychological as well as perceptual. The cues are in there, right? And their salience is increased by thinking about doing it. So that goes on for a while, and whether it's a few minutes or a few hours, and we can call that an intensification phase. And then eventually you go and you do it, and you get it, unless you don't do it. But if you do it, you do it. And then you get some relief, and you get learning, because that's simply operant conditioning. That's operant learning based on a reinforcement. And then you get loss. Okay, and as I mentioned, loss, that kind of loss, and especially that loss mixed with shame, is part of the driver for repeating the cycle. So if that cycle goes on every day or every couple of days, week after week, month after month, year after year, you are developing a very powerful habit. And most of what we do is habitual. I think most of us know that if we think about it. Almost everything we do is habitual. But this particular habit becomes more and more refined and entrenched and concretized and so on and so forth. And it's just a developmental habit, although it's an extremely nasty one. So we can just call that development. Or we can call it sensitization. Incentive sensitization. Robinson and Berridge. This is this sensitization to particular cues, and other potential rewards, reinforcers start to fall off the radar, right? So that's kind of the developmental picture. That's the way I would put it. What about the brain? Well, this is going on in your mind. What's going on in your brain? Well, it's really hard to show synaptic changes on a PowerPoint slide. I've tried different ways, but I found this one recently. I don't know how many of you know, people often think of development as the growth of synapses, the increasing synapses. In fact, the developmental progression goes in the opposite direction. Young infants and young children have an overabundance of synapses, which are gradually pruned with development. And what that pruning does is it strengthens it strengthens the synapses that are in use to achieve certain goals, and it prunes the other synapses. So you get rid of the synapses you don't need. And I always compare this to changes in a community where in childhood you've got a bunch of dirt roads leading from one dwelling to the next. And over time, they're replaced by streets, but there are also lots of little streets. And then over time, those streets are replaced by main streets, and some of the little streets go away. And then after a while, the main streets are replaced by highways and then freeways and so on and so forth. So you get more and more efficiency in the brain by dint of pruning away the unnecessary synapses. And of course, that's what creates habits. That is habit formation in the brain. So every time you go through the cycle of seeking and getting and relief and learning and wanting and needing and doing it again, every time you go through it, you are making synaptic alterations all over the brain, especially for our purposes in the striatum and the prefrontal cortex and many other, and in the amygdala and many other areas as well. So, see if this gives you an idea. Pruning the unneeded synapses until you have a superhighway. And that's your habit. That's your habit. And that's why it's so difficult to change. And that's one reason why neuroscience is such an important addition to the way we think about addiction. Because I don't want to say that addicts don't have a choice, and I don't want to say that they can't stop. I know that that's not true. But I do want to say that it's hard to stop. And why is it so hard? Why can't you just wake up one day and say enough of this? Well, because you have a highly entrenched, ingrained habit, which is manifested through synaptic configurations that you have built up over at least months and quite possibly years or decades. That means the change isn't easy. So that's one of the really important lessons that neuroscience can provide for the understanding of addiction and recovery. Okay, I'm not going to go for a full hour, but I'm gonna go for a few more minutes, and I kind of like this particular slide. What this shows you is these are changes in GM volume, gray matter volume on the y-axis, and years of use on the x-axis. And this line represents, this is a regression line showing gray matter volume, which means the density of synapses for people taking alcohol, cocaine, or heroin. There it is. Alcohol, cocaine, or heroin for 5, 10, 15, 20, 25 years. What you see is a reduction in gray matter volume in very particular regions of the prefrontal cortex, or the regions between the striatum, kind of on the pathway between the striatum and the prefrontal cortex. Okay? You get this loss of gray matter with years of use. And there's the population baseline, people who've never taken drugs. Well, people who take a disease orientation, including neurovocal and all the folks at NIDA and all that, they look at these things and they say, well, obviously there's a disease going on. You're losing your brain, right? You're losing your gray matter. But what if you think about those changes in terms of pruning, in terms of developmental pruning? It's a whole different perspective. If you think of it as a developmental process involving pruning, then what you're thinking is that you are getting more and more efficient, if you like, more skilled at being an addict. And you don't need as many synapses in those regions for making choices and judgment and thinking about the future, partly because you're not making choices and judgments and thinking about the future. You know what you're going to do today, the same thing you did yesterday. Which is not a particularly wonderful way to live, but it is a way to live. So if we think of these changes in terms of pruning, that the loss of synapses is not the end of the story. And we ought to see in recovery further synaptic alteration. And in this particular study, we do. So what this shows is that people who have been abstinent from alcohol, cocaine, and heroin for a period of 20 to 40 to 60 to 80 weeks, there is an increase in synaptic density in very similar regions, not precisely the same regions, but I'm not sure if that matters. And what's most interesting here is that you get increasing synaptic density that goes beyond the population baseline for people who have become abstinent. I'm not saying that abstinence is the only way out of addiction. It's certainly one way. It's a pretty good way, but it's not the only way. But what's happening there, it's a matter of speculation. I've talked with the senior author of the study, and we both like to speculate that what's going on is that people are developing new mechanisms for emotion regulation. They're developing new skills for self-control. Well, that takes work, and it takes building up new synaptic pathways. And what I expect would then happen eventually as those become streamlined and entrenched is you're going to get then synaptic pruning again. And part of that synaptic pruning ought to be the no longer thinking about drugs or booze or porn or whatever it is, or gambling, no longer thinking about that as a resolution to your needs, to your depression, to your anxiety, to your discomfort. It just starts to go by the wayside if you stop thinking about it. Okay, so conclusions. Severe addiction is like a disease in many ways. The idea that addicts need help, not punishment, has been championed by the disease approach, by NIDA and other organizations in the US and elsewhere. And that's been great. That's a step forward, but it doesn't have to be the last step. This can be a step on an evolutionary pathway in how we understand addiction. Okay, so the problem Again, neurobiological change does not equal pathology. That's one way of looking at it. Neurobiological change can also be understood completely from a developmental perspective. So I think we need to use insights from neurobiology to help understand developmental processes that lead to negative outcomes, including addiction, of course, and others as well. And we also have to pay close attention to social processes and societal resources. I think that's pretty obvious to anyone who's thought about it, is these things are not happening in a vacuum. The people's thoughts and feelings and habits and synaptic pattern formation are all happening within an intensely powerful social matrix. Yeah. So those kinds of things, I think, we recognize them as a kind of a common sense way of understanding the problems that people have in addiction. But I think that they work better with a developmental approach than they do with a disease notion. Because you can't really necessarily get rid of a disease by changing the social context. But you can alter a developmental pathway very much by changing social and societal elements. Okay, so, but still, you may ask, even if you've taken what I've said so far as being reasonably legitimate, you may ask, how will addicts get the help they need? And this is a big deal, and it's especially a big deal in the U.S. And I recognize this. When I was in Long Island a couple of weeks ago giving a talk, and okay, so I want to bash the disease model, and that's good for me. But there's all these opioid addicts out there who need Suboxone and methadone. And if they don't get it, they're very likely to go to the street and get heroin instead. And that heroin is quite likely to be laced with fentanyl or its many analogs, and therefore they're likely to die. So we need to have resources available for them. So there's obviously a strong argument for having some kind of resources available. But other than that particular situation, what we offer, the kind of help that we offer addicts in disease-oriented rehabs and treatment centers is often really not very effective. We've got medical personnel who don't have psychological tools, who don't have expertise in psychology, social work, mindfulness, meditation training, all kinds of things that can really help people change the way people connect with their lives. 85% of these rehabs and treatment centers still rely on 12-step methods. Again, that sort of unholy marriage between the disease concept and the idea that there's this fundamental flaw in one's makeup that will never go away. Okay, and they're not very effective, by the way. AA is useful for some people, but it's a pretty small percentage. It's something like 5 to 8%. Poor outcomes. Everybody knows that if they've been involved in any way with rehabs and treatment centers. It's a revolving door. People go back 2 to 10 to even 15 times. They cost a lot of money sometimes, anywhere up to $100,000, even $150,000 a month. You know, and if they don't work very well, that's not very good use of your family's resources. And it's a high-profit industry. There's, a lot of pariahs and really nasty stuff going on if you're interested in learning about it. High profit, it's a quick fix. It's driven by a quick fix insurance industry that wants to get the most bang for its buck, and therefore you're in for 30 days and then out and back in your lonely little apartment in downtown Pittsburgh or whatever. You're very likely to start using again. So it's just not a very effective treatment system as it stands. So I couldn't resist including this slide. I saw this in an airport in Australia. I'm not just a GP, I'm your specialist in life. Well, no, you're not. You're not necessarily a specialist in life. You're a specialist when it comes to physical problems, bodily problems, of course, but you're not a specialist in everything. And I think most doctors realize that. So doctors may not necessarily belong on the front line, although they're a very important adjunct, especially when it comes to addictions that involve chemical dependency, like opioid addiction. Okay? So then my final it's maybe my last slide. What kind of approach should we take? What kind of thinking should we use to think about how to change the way we deal with addiction as a society? Well, how do we try to fix society's other serious problems? racism, bullying, domestic violence, poor parenting, teen pregnancy, loneliness, for example, in old age. I'm sure you can see the list can go on and on. These are serious problems. Governments, public health organizations, networks, social, neighborhood organizations, all of these sorts of sources have thrown a lot of energy and money at these kinds of problems, but they don't call them diseases. We don't have to call something a disease in order to get really serious about trying to fix it. So I want to leave you with that idea. We don't have to call something a disease in order to throw money at it and to build in resources for changing it and fixing it. And by the way, these social problems have a lot of resemblance to addiction. They all involve entrenched cognitive habits. They all involve poor emotion regulation. They all involve some kind of entrenched belief, like addiction. Those are pretty much psychological issues. And so I think that the ways that we try to deal with these issues are through community resources, counseling and psychotherapy, to be sure. I would also include mindfulness meditation training. Has been found to be quite effective for helping people with addiction, at least as effective as any other psychological tool, like motivational interviewing or CBT or any of the rest of it. It's really, learning how to meditate, it can be pretty powerful. Social support, family, friends, community, etc., and education. And I think education is really critical and should start early in elementary school. As I say, being an addict is not fun. Kids don't want to become addicts. And if you help give them the tools to recognize when they're starting to move in directions that might lead to addiction, they will steer away from it if they possibly can. There's been a lot of, you should read the book Chasing the Scream by Johann Hari. Great book about chasing the scream, the first and last days of the war on drugs. And one of the things he does is reviews how other societies have dealt with the problem of drug addiction. Portugal's a great example. They had a 1% heroin use statistic. 1% of the population were using heroin. That was about 13 years ago. And then they called in a whole bunch of experts and said, what should we do about this problem? And the first thing they said was decriminalize it. Really? Seriously? Decriminalize it? Yeah. So it was decriminalized. People were no longer thrown in jail for using it or for selling it. And what was done instead was that there was mandatory counseling or psychotherapy of some sort, and other policies taking away the driver's licenses of people who continued to use and so on and so forth. But the main way of reversing the tide of addiction to heroin came actually through the school system. High school kids talking to each other about, yes, heroin is available, but you'd be an idiot to go that way. You don't want to go that way. And it was a matter of discussion and a matter of thinking and feeling, what are the other alternatives and who's at risk and how can we help them. And so I just think education and taking advantage of the instincts and potentials of young people can be hugely helpful. That's it. Thank you.
Hi. Nassima. Hi. Nice meeting you. Hi, everybody. I'm Nassima Ait-Daoud, and actually I'm a psychiatrist, an MD. And an addiction specialist who spent the past 20 years working with addicts, actually, not behind screens, and learning about it. A lot of my research has been on addiction. And I hope that, Mark, you don't feel like you're in line. I hope you don't feel that the U.S. is actually closed up to any theory that we do love to learn from one another. I think one of the theory in the U.S. is that there are different approaches to treating addictions, and there is no one that's going to fit everybody, and that we have to open our minds and we have to allow different ways of treating addiction. I did participate in a lot of NIDA grant reviews, and I have to say that there are a lot of psychologists over there. They're actually MDs are not too often represented, and that there is even an effort to try to promote physicians, because there are actually a lot of more psychologists than physicians in NIDA. So my job today is actually to go and say that no, actually, addiction is a brain disease. So forget everything that Marc just told you. And actually, addiction is a brain disease. Although I really enjoyed your presentation, and a lot of the times we're not going to disagree. We're going to agree. It's just sometimes it may be semantic, and we'll have to leave it to that. So figure out how to move things. So I put this picture here. Because, and it's perfect because Marc showed that picture of beautiful people with addiction and saying, we hope that there is no stigma. There is a stigma. They do trigger strong reaction in us. We do have strong reaction when we see patients who come in the ED. They're usually violent. They're usually cursing at us. They're usually rejecting our help. So it does trigger strong reaction in people, physicians, psychologists, providers, family members. And when we say that addiction is not a choice, I don't know that we're saying that people don't have a choice to go use a drug or alcohol. I think that the way I see it is that nobody's born saying, you know what, when I grew up, I choose to be an addict because, I think that's a cool thing. People go into it not wanting to be an addict, not wanting to have addiction, but they do get into it. So, because we're talking about disease and disorder, or is it a brain disease? I didn't want to put the definitions actually by the medical dictionaries. What a disease is. Disease results from a pathophysiological response to external and internal factors. A lot of times people see disease as an external, something that caused our body to change, something that caused our brain to change that is external. And disease is often construed as a medical condition associated with specific symptoms and signs. It may be caused by external factors or by internal dysfunction. It's the highest level of conceptual understandings. When we really know, when you put that factor, you put it in the body, it causes that. We know that's a disease. Disorder is a little bit more, not as clear, and it's disruption of the disease to the normal or regular function in the body or part of the body. So this definition, look at it, is that you can still have a disease. You have a disease, and then the disorder is the things that the disease can cause, or it could be just a functional problem that you may have. It's considered value neutral and less stigmatizing than the term disease, and therefore is a preferred terminology in some situations. In mental health, for example, the term mental disorder is used as a way of acknowledging the complex interaction of biological, social, and psychological factors in psychiatric conditions. Again, disease and disorder, you don't have one or the other, you can have both. But so Marc talked about impulsivity and compulsion, and I do want to talk about it briefly, is that a lot of times when drugs or even a behavior, even gambling or sex or porn is started, there is an impulse need to it. When we talk impulsivity, is that there is that you do it, and there is gratification, there is a reward in the beginning, and then with time it becomes a compulsive need. There is this anxiety and stress before committing it, and you need to do it repetitively to relieve that stress. So in the beginning it was reward, and then it became stress. I know Marc talked a lot about dopamine, and dopamine is big in addiction, but we do know that in the brain model, in the disease model, dopamine is not the only actually neurotransmitter. Is not the most important one. But so drug use progression, what we've learned is that drug taking behavior, and you'll see that I say drug taking, it could be replaced by behavioral addiction. Drug taking behavior progressed from impulsivity to compulsivity in 3 stages. There is, and that's you're familiar with that. That's NIDA, Nora Volkow, big thing, and now even Kube. So there's a binge where there's positive reinforcement people use because they really get high from it, and then they try to stop. There is a withdrawal, negative effect, and they don't like it, and then they use again, and eventually there is changes that causes people to have this. They're always preoccupied with it, anticipating to use, and it becomes really a negative reinforcement because people are trying to move away from the negative emotion if they don't use. So, is there? Oh, okay. So why am I interested in addiction being a brain disease? Because in addiction, I feel that there was so much research that was done that we were able to identify circuitry in the brain that are associated with the different stages of addiction, the binge, the withdrawal, the preoccupation. Are they solely responsible for just addiction? No, they're part of different function. But what's really exciting about addiction is that it's the same model that was actually identified in animals, that we were able to see it in humans, and that's pretty exciting. Is that, you know, we take rats, we feed them cocaine or alcohol, cut their brain, slice their brain, freeze their brain, do anything, and we're able to identify areas. But then with the development of neuroimaging, we were able to see that the same area that we identified in animals was also affected with addiction. So, and I'll go really slowly through that, I won't bore you, but the binge intoxication, that's where the dopamine release is actually causes the high. I know you talked about sex and love and food and, you know, doing all these fun things, but for things to be addictive, there has to be a steep increase in dopamine. It's not anything. When I take a shower in the morning, I do get a dopamine release. I do feel pleasure, but it's not addictive. I don't know that anybody has been addicted to showering, although it wouldn't be bad. But it's really that fast and steep increase in dopamine that really makes a difference. And not everything will cause it. And the more dopamine release there is, the more likely that this that drug or that behavior is going to cause addiction. Then there is a compulsive phase. So these incentive salience really, when we drive motivation and reward from these behavior, you know, what happens is that that dopamine release that was induced by drug administration activate some of the area of the brain that are exactly the same area that we see in OCD. So everybody understands that when somebody has OCD and has, you know, problems with germs, and they have thoughts that their hands are dirty, and then they go wash them 100 times until their skin falls off. Nobody has problems understanding that it's really hard for them. You can tell them, they have a choice. You can tell them, you know what, you know you don't have germs in your hands. You know that you just wash your hands 100 times. You could stop. Yes, they could stop, but they will do it to the point that they'll bleed. And that's the difference. That's the compulsive nature of addiction. When I work with patients, I had a patient that told me is that I hate myself because when I go get my check and I have my check and I look at my kids and I look at their eyes and I know I need to get diapers for them and I still look at them in the eyes and leave and go get my heroin. And I hate myself for that, but I can't do it, and help me stop it. So that was the dopamine in the beginning, and what we know is that later, as they continue to use, the prefrontal cortex is actually affected, and that becomes more of glutamate and other things. And prefrontal cortex is really where we make executive function, we decision. You know, we should we go buy a diaper? Should I go get my drugs? It really affects, again, self-regulation, inhibitory control, work and memory, decision-making, a lot of things, and that is affected later. So we know that genetic, environmental, social factors contribute to the determination of a person's unique susceptibility to using drugs. Not everybody who's going to be taking drugs will develop it, and there is a lot of research that is looking into who will develop it, what are the factors, what are some of the things that could be done to avoid it. So yes, there are childhood trauma, there are multiple factors happening, there is learned thing, but all that, when it affects the brain, it causes a disease state. The reason why I say it causes a disease state, because it's the same pathways that we see in animals that if stimulated by the drug would cause exactly the same behavior over and over. Again, the relevance to behavioral addictive disorder, we found we couldn't get animals to gamble, we couldn't get animals to do porn, so we don't have a good model for that. But when we did neuroimaging with humans, we found similarities between drug addiction and behavioral addictive disorders. So this is I like to put this here because it really goes against the theories that it's a developmental disorder, that it is something that we learn, that it's childhood trauma, that it's PTSD, that will put somebody at risk for addiction. I think the opioid epidemic has shown us differently. I work a lot with women who had never had an addiction problem, get pregnant, go to deliver, get a C-section. The OBGYN give them some opioid, release them on opioid, and before they know, they're addicted to opioid. Nothing in their childhood, nothing during their adolescence, yet they develop it. So, and this is another way of looking at it, is these are people who had no addiction and developed Parkinson's disease later in their life. And treatment of Parkinson's disease is a dopamine agonist, which is really in that work in that dopamine area and feels like you're doing drugs. But people who were given Parkinson's drugs developed pathological gambling, hypersexuality, and compulsive shopping, and on people who never had it. So really, you take this circuit that we know is responsible. We see it in animals, we see it in humans, and then when we manipulate it by giving, even to people who don't have a history of addiction, and we give them drugs that will affect that area, they develop behavioral addiction that they've never experienced before. So that's one of the things that I found it to be really amazing. And it really gives us an idea of what this circuitry is able to do. So, addiction is a chronic brain disease with multiple etiological sources, all resulting in measurable changes in the brain, function, morphology, and consistent symptomatology. The aberrant impulsive and compulsive behavior that are characteristic of addiction have nowhere else been so clearly tied up to neurobiology like in addiction. Yes, we talk about biology and depression. Yes, we talk about biology and schizophrenia, but nowhere else has it been so well identified than it is in addiction. I feel that addiction has owned it. I feel that calling it a disease, it doesn't take away people's choice. I mean, we have choices. We never say that to the OCD patient, you don't have a choice to washing your hands. It does open doors to new ways of looking at treatment. I like to think that treatment is a multidisciplinary. I want to correct you in thinking that all physicians are just these people who are like, okay, how can I give you drugs? As psychiatrists, we trained in psychology, we trained in mindfulness, we trained in CBT, in MI, we train in everything. So when we treat our patient, we do a little bit of everything. I also do want to correct that residential treatment are, some of them are money-making. Though the residential treatment that I work with use mindfulness, CBT, MI, they do 12 steps, that's for sure, but it is not one cookie cutter for all. So again, because I feel that addiction has made so much progress, has identified so many things, and that there is a consistency in symptomatology that has not been seen anywhere else, I do believe that addiction is brain disease. Thank you.
So I think, Mark, do you, or are there any of the points that Nassima just made that you want to comment on before we open this up?
Sure. I don't want to spend a long time refuting, but when you talk about the incredible identification of circuitry which we see with addiction, sure, society has put a huge amount of resources into identifying the particular set of changes that go with addiction because it's such a serious social problem. But that doesn't, the fact that we have identified some of the neural changes doesn't mean that those neural changes bequeath pathology. We also, there are a whole bunch of neural changes that go on in adolescence, for example, or in religious conversion, or in all kinds of other things, which can be identified. Maybe not with the same precision because it hasn't been such an important societal agenda, But the whole point of my talk was that neural changes does not mean disease. So, and as far as the steep rise in dopamine as to, between the shower and the cocaine, NIDA, I think, has been irresponsible of not differentiating the dopamine that you get from psychostimulants from the dopamine that you get from your own reward system. I mean, they just never managed to do that. When they show these really classy fMRI slides with big red and yellow splotches based on psychostimulant drugs, the implication is that that's a product of the disease. No, it's a product of the psychostimulant that actually keeps
I have to correct that.
Keeps dopamine in the synapses.
So actually, it is. So actually, there is research that quantified the dopamine release, and what they found is that when you use cocaine, it releases 10 times more dopamine than sexual act. When you use methamphetamine, it releases 100 times more dopamine than sexual act. So there is interest in, I don't think they're putting everything into one bag and saying it's the same thing.
But that's, yes, so what? Some drugs put more dopamine in your synapses. Hold on.
Yeah.
You said the same thing is the case with anti-Parkinsonian drugs, and that's true. What does that prove?
It doesn't prove, what it proves is that with some of these drugs that have released dopamine in such a way, with continuous use, in certain people, there will be some changes in the brain that will cause the compulsive use. That if we are able to really target some of the areas of the brain, whether it's through psychotherapy or whether it's through medication, we'll be able to provide help to the patient who's struggling.
Yeah, so if you jack up the system with tons of dopamine, which you can get a lot of from psychostimulants, then yes, that will accelerate particular changes. Now with other drugs of abuse, like heroin, for example, you don't get nearly the same dopamine profile. And in fact, in a number of studies have shown that you get actually no change in dopamine uptake unless the subject is actually pursuing heroin. In other words, if it's being administered without their will, without their voluntary triggering of the act, they don't get any dopamine. So in other words, dopamine is a natural way of responding to attractive rewards. But of course, you can enhance it with chemicals. So what? I mean, you can also enhance serotonin with other chemicals and antidepressants. So what?
So there's a risk for addiction.
What?
So if you enhance your dopamine release, there is a risk for addiction.
Yeah.
Yes.
There's a risk for addiction. There's also a risk for uninhibited sexual behavior, which is not necessarily an addiction at all. In fact, in one of the case studies, a guy on anti-Parkinsonian drugs started to have gay lovers, and then been heterosexual for his whole life. So in other words, people will move more assertively, more quickly, saliently into all kinds of acts that they might not have considered because there's more dopamine in their system. But so what? What does that say about addiction?
What it says is that the prefrontal cortex has been affected and changed, so that the decision making is changing. So the person who's moved to gay, sexuality may have had it before and had made the decision not to do that. But then with priming the system multiple times, the prefrontal cortex that's making decision has changed, has shifted.
I think we're going around in circles.
Yeah.
We both recognize that dopamine enhances particular behavioral acquisition strategies and impulses and impulsivity. You can get dopamine from your own ventral tegmental area, from your brains, from your own midbrain, or you can get it from drugs. What it does is enhances certain attractive behaviors.
But not at the same level. That's the difference. Also, there are implications for treatment. So OCD has developed really the great development in OCD, where now we can do neurosurgery to treat OCD using gamma knife. We know that there are some pathways in the brain that are overly activated in OCD to the point that people are bleeding in their hands.
Yeah.
So we can do a gamma knife and cut some of these pathways without even having to open the skull, and people recover from OCD. It's amazing. So I like to think that we haven't seen yet the limit of what we can do to help people with addiction.
Yeah, I don't know the research you're talking about. I know that deep brain stimulation has been used with OCD and other things, so mixed results. But look, any psychological or behavioral state or condition or difference is going to correspond with some neural behavioral state or condition. I mean, I just take that as a given. And the fact that you see it in both humans and rodents, so what? We're all mammals. I just don't see the power of that argument.
So what is the power of your argument? Is that it's learned behavior?
Yes. Oh, yeah, you heard about that.
Yeah, but learned behavior has neurobiological changes, right?
Oh, yeah.
Yes.
Oh, yeah.
And
The infant brain and the adult brain look hugely different.
But your theory is that we develop addiction is a developmental thing, and I'm telling you that it's not true for everybody. That there are cases, or there are a lot of now cases with opiate addiction.
Absolutely. There's no developmental thing that is the same for everybody. That's why that diagram of multiple differentiating pathways is what I try to use to indicate that. Look, there are individual differences in everything. It's certainly in development, and all we have to do is look around us to recognize that there are huge individual differences. But so what? Again.
So again, I don't know that we're saying the opposite thing, and that's why I'm a little confused. So what I'm saying is that, yes, there are multiple ways of getting into addiction, multiple ways, right? You could be tied to a chair and somebody's pushing heroin and into you every day, and you'll develop an addiction.
No, you won't.
You will develop addiction.
No,
but
you will develop chemical dependence.
yes, and then eventually you will develop addiction.
No, that is not the case.
So we'll have to agree to disagree here. So with the brain disease, there will be multiple ways of getting there. So what I'm saying is that what we know is there is a set, really well-defined circuitry that is affected in addiction. And when that is affected, we have the same symptomatology, whether you go to China, wherever you go, when that circuitry is activated, we see the same symptomatology over and over. Yeah. And that's the definition of the disease.
When people have sex, you get very specific changes in the testosterone system, the dopamine system, the oxytocin system.
You do,
So
but you don't do it to the point that you have negative consequences and still maintain it. You don't become homeless so you can have sex.
Yeah, but that's a normative social decision for how to classify something. That's not a biological explanation.
And there is a biological explanation where the prefrontal cortex changes, the way the prefrontal cortex changes so much that the decision making is affected, and then all
That's
these
called
people,
adolescence.
Sorry?
That's called
No,
adolescence.
you see it in these Parkinson people who were given drugs.
Yeah, the prefrontal cortex
They're not
changes.
adolescent.
Yeah, but the prefrontal cortex changes a lot in
Yeah.
other circumstances, such as normal adolescent development.
True. I think what we're struggling is, and I saw that in your slide, is you're saying neurobiological changes is not addiction. I agree, neurobiological change, you see that when you exercise, you see that when you do everything.
Yeah.
But that what we're talking about, there is a set of neurobiological change that we see over and over in addiction that's very specific to addiction, that causes the same symptomatology, and that it opens doors to it doesn't close door, it opens door to more rather than less.
All right,
That's
so,
why I'm
all right, so we have to find some, punctuation point on this. And I think what I hear is, by way of transition to see what other people, want to say about this, is whether the changes that you have just described can be understood within the learning model that Marc has provided, or whether they can only be understood as within a pathological disease model. I mean, I think that's why I said at the beginning, that this is at some level, it's a technical question, because I think you agree pretty much on the evidence, on the phenomenology, and on the evidence, and particularly the neurobiological evidence. And so it's the characterization issue, I think, that is of concern here, which then leads to the question, does it matter which way you characterize this or not? And I would like to kind of direct the discussion in that vein. And I have some things to say about it, but I think we should see what else Andy Thompson wants to say about it.
Thank you very much for your talks, both of them. maybe a way to break the deadlock just for a moment. I would be curious, Dr. Lewis, how you would view the case that Dr. Ait-Daoud mentioned about the individual with no history that we know of, who, say, the woman who delivers C-section is given just some opioid, and then, develops very quickly a severe addiction. I mean, how do you look at that through your lens?
I'll tell you. From what I've read, people who take opioids for pain have a 1% of developing an addiction if they have no previous drug history, and a 10% chance of developing an addiction if they have. That's a low percentage. So, I mean, if your mother or grandmother takes oxycodone for her sciatica or something for a few weeks, do you really think she's going to become a good addict for life? That is not a common pathway.
No, I understand it's not common, but I'm just saying, when you come across such an individual, how would you think of that person?
Because sorry. I'm not sure about the end of the question.
But how would you conceptualize or think of that individual, that rare individual with no history, who does suddenly, with very little exposure, develop a pretty serious opioid addiction?
Okay, so that 1 or 2%.
Yeah.
I think that's a really interesting question, is what's different. Sorry, did you want to get into that?
I did. So there's literature actually now saying that statistic turned out is a very flawed statistic, though that research has been called into question. One of the things that's very interesting is it turns out that short-term exposure to opioids are extremely addictive, and one of the reasons we're in this crisis is because we were all taught as physicians that there was no risk with short-term use.
No, I
so
know.
there's a lot of literature that's
Sure, exposure to opioids can absolutely
but
trigger
I mean, it's
addiction.
much higher.
Especially if you're poor, if you're in crisis, if you have a dysfunctional
No.
family. Oh, yeah.
No, I mean, I'm just saying in terms of just the actual exposure to it.
Yes, I understand. Also, if you're exposed to porn, you're much more likely to become a porn addict.
But I also wanted to just say, I'm a psychiatrist also, who has done mindfulness-based stress reduction and all sorts of other things as well. But one of the things that when you spoke at your talk, when you used the example of binge drinking, you said everyone will, many people will drink in college, they'll binge drink in college. Their behavioral drinking, like excessive binge drinking, does not necessarily set somebody up for addiction unless they have a genetic vulnerability. And so what happens commonly is you see people in college, you'll see people who will have binge eating disorders or binge drinking disorders. The vast majority, like 70% of them, will go on to just live their lives. They're done with it in their 30s, as you said. But there's a subgroup of people who are genetically vulnerable who are going to become addicts simply by virtue of the way in which they were not raised, but they were genetically vulnerable.
Yes, so they may also become suicides, they may also become depressives, they may also become a lot of other things. And the behavioral genetics is hodgepodge. There's absolutely no constellation of genes that predicts to addiction. However, certain character traits predict to addiction. I mean, what behavioral genetics does is it adds variants from these various character traits. So if you have an antisocial or risk-taking personality trait, you're more likely to become an addict. If you have the opposite personality trait, and if you tend to be neurotic or introverted or shy or socially seclusive, then you're also more likely to become an addict. So there are certain personality traits, and just about everything has a genetic linkage of about 40 to 60%. Anything's been measured in psychology. The big 5 personality factors, it's all 40 to 60%. So it's just not a very satisfactory explanation for addiction.
No, I just wanted to make those two observations.
Certain people are more vulnerable, but the reasons are complex.
Did you want to?
Yes, thanks, Richard. So thank you both for your talks. I think we got really close to an interesting insight during that very brief moment when Nassima, you said that would be a disease, and Marc, you said no, that would be a chemical dependency. Maybe you could speak about a little bit more in terms of how it is that you differentiate between those two things. So I think, Nassima, what you had said was if you just pushed a drug on someone, eventually they would become an addict. And Marc said no, they become chemically dependent.
Well, may I say something about this?
Yes.
Because my understanding about the diagnostic criteria is that the idea of physical dependence, which I think is what we're talking about here, has been separated explicitly from the definition of the diagnostic criteria of, let's just say, opioid use disorder and, in this extreme version, addiction, right? It's the drug-seeking, aspect of it and the behavioral features that are the cardinal aspects of the definition of the DSM disorder, the extreme form of which is addiction, right? And it's made clear that we do not include in that definition the being physically dependent, upon the drug and needing it and having tolerance and then, having withdrawal. Because that can be induced other ways that are completely independent of the phenomenon that we've described, whether it's a learning model or it's described in some other way. I think that distinction is built into the diagnostic criteria.
Marc, what do you think of that?
I totally agree. To me, it's pretty simple. If you take antidepressants, SSRIs, for weeks or even months, you're going to have severe withdrawal symptoms if you stop. When you stop, whether you're depressed or not, has nothing to do with it. Same goes with beta blockers, blood pressure medications, a whole bunch of drugs that create chemical dependence. Doesn't mean you want them or like them in particular. It just means that your nervous system has been altered by these drugs in such a way that there's a rebound effect. So I think that is really quite different from the psychological features of addiction in which you feel that this is the only thing that's really going to make me feel happy or feel okay or feel complete.
And this is one of the things. I think they agree on the phenomenology of addiction.
So let Nassima respond to that.
Yeah.
So, yeah, and I think maybe I didn't clarify is that, yes, if you put 10 people here and push heroin every day or morphine, whatever you want to give them, that not all of them are going to have the disease, right? There, some of them are going to have the dependency where if you stop, they will be neutral, they'll be miserable, but others will develop, and then we let them go. Others, some of them, maybe 1 of 10, about 10% will develop the disease, where we'll lie, we'll go get it, we'll sell things, we'll do whatever it takes to continue to get it.
Okay.
So that's the difference. It's not everybody who will do drugs will develop addiction.
So this entire conversation at this point is revolving around that 10%.
Yeah.
Subpopulation.
Not everybody develops an addiction.
So I think we all agree that some people are more sensitive and more at risk for addiction than others. I think we all agree on that. And so sometimes the gentleman in the back was saying that there is that person who you never would have guessed, sort of thing, who becomes addicted. But a lot of psychological issues are not on the surface. They have to do with things that have happened a long time ago and one is not conscious of. So, and people don't get addicted to bananas or certainly not cucumbers. People get addicted to things that are attractive, things that give you a big bang for the buck. And that's why, some drugs are particularly addictive in the psychological sense, never mind the chemical dependency.
I was hearing an interesting article on the news. I was driving, I think it was on NPR, and there's a phenomenon now that people are describing that if you give a patient a narcotic intraoperatively while they're under anesthesia, they will wake up with more pain and actually will trigger a craving for the medication. That it's the process of being anesthetized that sets them up. And so there's a huge push now in anesthesiology that's starting to look at that the time that you can give somebody a pain medicine is as they're waking up coming out of anesthesia, but if you actually inject them intraoperatively, you have set them up. And so it's a major push. So there's all these things that physicians have inadvertently done in the service of trying to protect people from being in pain, that have set up these kind of amazing things. And the only other thing I would say is that part of the other thought that people have in terms of the opioid epidemic is that there was a psychiatrist who came up with the concept of direct marketing to patients. It was OxyContin.
Oh yeah, that was Joe.
Right, and he actually said you cannot get addicted if you're on a tiny dose of it.
Yeah, it was bullshit.
So we set ourselves up for a lot of these sort of vulnerabilities, but I think as we expose huge populations to these things, we do end up with people self-medicating because of pain and angst and stuff. But there is a small group of people who do self-medicate because they are truly biologically set up for it.
Or psychologically set up
sort
for
of
it.
psychology.
I was one of the 10% or so, having had a history of drug abuse in my youth. I got severe spinal stenosis about 7 years ago, and led to a lot of pain. And I started getting large amounts of oxycodone and also a fentanyl patch. Then I got surgery. Then I weaned off the drugs in about a month and a half, and I was fine. I'm in no pain now. So I don't have any wish to return to opiates. So it's not magical. It's not an evil force, that invades your system and is there forever. It's very much depends on how you are in your life, how you feel, and the kinds of support systems you have, and also your experience with drugs themselves. Because, as I say, most people get sick of it and stop.
Or die.
Or die. A few die.
That's thank you both for your talk, as others have mentioned. Dr. Lewis, one of your last sort of question, or the sentence on your topic slide, does it matter? And I'm wondering, but both of you sort of, we're talking about this sort of somewhat dichotomously, but both of you have mentioned sort of the integration of both of your views in many ways, with differences, of course. One thing I'm curious about, I'm a psychologist here in our health system, and I'm curious about the treatment implications that both of your models have and how we treat addiction. Would love to hear your thoughts on that.
So, and this is a meet, he and I work together, so treatment for addiction includes both pharmacotherapy, and the brain disease model has really helped because we're able to really identify in the brain areas that we can target with medications. It works better for some than others. Opioid is one of them that works really well. Alcohol dependence has, 4 medications that are approved for treatment. So what we know is that therapy, whether it's CBT, there's a lot of things done on CBT now. Mindfulness is getting a lot of attention. Is that it causes some of the change in the brain that we see even with medication, and then what we've learned is combining both medication and therapy is actually one of the best way to do it. We've also learned through some of the work done on neurobiology is that exercise is another way that is getting a lot of attention because it seems to affect some of the brain circuitry and reverse some of the damage that was done by addiction. So there is no, the way I see it is a behavior. You can look at it from a biological thing and say, there's this dopamine release, this thing, that's why there's a behavior. You can look at it as that, yes, there is a learned thing, that's why there is a behavior, but I'll say that the learned thing can cause the brain and that change in the brain, and change in the brain can cause the learning thing. So I'm not saying one exclude the other one, it's pretty much the same.
I think we would agree that some drugs and many psychological or psychosocial interventions are both often helpful. But I think the great promise of developing new chemical interventions for addiction that came with NIDA that we've been talking about for 20 or 30 years haven't happened. I mean, so we've had methadone for, 50 years? And now we've got Suboxone as well. So what? We've got naloxone or naltrexone, which you can combine.
I have issues when you say so what. Suboxone is saving lives.
No, I don't mean that.
Yeah.
I mean, we know that if we give opioid addicts other opioids, they are less likely to go back to the street and buy heroin and do whatever they have to do to buy heroin. And that's a very good thing. But that's not rocket science. That's replacing one opioid for another. But sorry, anyway, it's evidence-based. It's absolutely a very, very important treatment vehicle for people for opioid addicts. And it absolutely should be available for them.
I have to say that we agree on the fact that abstinence is ideal. right? Abstinence is really what I try to help my patient achieve.
Except with alcohol.
Abstinence is what I push my patient to achieve. For some, being on Suboxone is really like a miracle for them, and the number of lives that it saves, to me, it's close to a miracle.
I totally agree with that.
Again, the model that we put together can actually help open new, like I told you, neurosurgery is going to be next, because we know some of the surgery that are affected, that we can use gamma knife, we can use TMS, we can use other things for those who are not benefited from therapy and medications.
That would be nice.
Yep.
You can try.
So I'd like to make a couple of comments here as a consumer of the science and the different perspectives that we've had here. I have been wondering about the so what question. What difference does it make whether you use the characterization, of the disease or not? And I think if I understood everything that Mark said here and that what he's written, that I don't, all the reasons that what I've called the public health establishment, has been emphasizing the value of the brain disease concept, and all the reasons that they are trying to do it in order to promote a caring and compassionate response and an understanding of what can be severely disabling for people when they are suffering and dysfunctional, even if they can over time sustain without treatment and recover. That at least for those people, what they want is to provide better access to care, more compassionate care, and so on. And part of their reason for using the brain disease formulation is they think that it helps promote public policies that do that. I think that's the clear, to me. You said at some point and what I think is important about your work is that you root your model, the different model, in the neuroscience, and that I don't think you all disagree at all fundamentally about the neuroscience, here, and about the phenomenology of addiction, and particularly even if you get rid of the word disorder and the DSM, the cardinal attributes of opioid use disorder, cocaine use disorder, and particularly the severe end, with addiction. I don't think y'all disagree about what those attributes feel like and look like, right? So the question is, so what are we disagreeing about here, other than what I characterized at the beginning as potentially a technical question that boils down to what are the cardinal attributes of a disease? So what do we mean when we use the term disease as opposed to something else? In this field, forever, until the political statements have been made about this, we are using the term disorder. It's the DSM term for this. It doesn't imply anything about causation. It's the phenomenology and the severity of the symptoms that matter, and the dysfunction and distress. I don't think we disagree about that. So the way that I'm trying to understand this is, I got a choice between using the term disorder or using the term disease, right? I mean, I think just in terms of communicating the common understanding that we have. So as a person that's trying to accomplish sensible things as a matter of policy, what is the downside, of using the term disease? Or I'll put it the other way. What is the effect, one way or the other? Does it have positive consequences in terms of facilitating better public understanding to use the term disease? If it does, what's the downside of using that disease, using that formulation, and is there any? So I think there's a rhetorical question here that I really am trying to figure out whether there's a problem with it or not. Then I think apart from that question is the clinical question, which as I mentioned to you, I think is important too, because I know that you have said that you think from a clinical standpoint, it may not be helpful to some subset, at least, of people who are experiencing addiction, to imply that they are powerless by characterizing it as a disease, and that is the pushback that we might have, because it actually may not accomplish positive consequences, and it may have negative consequences at the clinical level for at least some people. And okay, now, maybe that's so. This is an empirical question about what would be the clinical consequences of doing this. How does it affect recovery, and how does it affect people? And there may be some that there's some way, and other people that find it helpful. You know, these are empirical questions that we really could, you know, could attend to. My inclination is to think that there's nothing inconsistent with saying that it's a disease for telling people that you have the responsibility to manage your disease successfully. And these are personal choices. We want to empower you to have greater control over your condition, right? And calling it a disease is not inconsistent with that. That's true of all chronic diseases, including diabetes and heart disease, anything that people might have, where you have to exercise care to manage your own condition and govern your behavior in a way to prevent you to hope to get better and prevent it from deteriorating. I don't see any difference with addiction in that. You want people to manage their lives and take control over their lives. The question is, what is effective in helping them do that? If this could be effective and helpful, well then that's a good reason to do it. If it's subverted, as you are worried about, well then I think that's important to know. So the way I see this is, the so what question depends upon, is it useful? Is it useful? Because you conceded in your talk something like severe addiction is like a disease in many ways. It does have there's some analogies, it depends upon your technical descriptions of disease, and so on. But if it's like a disease in many ways, the question is it useful to use that phrase? If it's a plausible phrase, is it useful to do it? And I think my inclination in reading everything is, I think it's useful. I think we are seeing the evidence of that right now in terms of, and again, it's not only the language, okay? I mean, I just think it's more awkward to use a lot of other phrases, that can be used about this. I think this is something that, that resonates at a certain level in terms of what we're trying to do, which is to care for people and be compassionate and be helpful, to people and stop criminalizing and punishing and so on, all the bad things. And particularly given what we have to do to cope with this multifactorial, the channels that are feeding so many more people into addiction that is tied up with the pain management problems. That's why this is happening now. I mean, there are a lot of other factors that are going into that in terms of culture and racism and so on. But this is happening now, and again, this is why I said, this is why I wanted to do this program. This matters right now. We want to get more money for Medicaid. We want to get more funding for drug abuse treatment, substance abuse disorder treatment. And we need it. I mean, this is not, this is really consequential. And what is going to be most helpful, actually, in accomplishing the political, the social policy objectives, that we have. And right now, my inclination is it may be a political statement and not a scientific statement, but it's the statement we ought to make, right? And it's not implausible, it's not wrong, right? Okay, I guess that's partly what, my feeling is, I think your model is persuasive to me, just in terms, but since it covers the same territory, right, as something else that's being characterized another way, I want to accept that this is, the heavy-duty, hard learning, model is a good and useful way of understanding what is happening with people. But we have to give it a name, right? And right now, I do think the choices are, opioid substance use disorder, because that's the term of art with regard to any kind of clinical intervention. And so we can use that, or we can use the term disease. And if it's useful in public rhetoric to use that term, it's not implausible, to use the term, and that's all I need to be persuaded, by in order to do this. So this is actually the reason I wanted to do the lecture, because I wanted to give that speech. Right now. All right, does anybody else want to say, either one of you, I mean, I could run the gavel down and say we're done, or do you want to have the last word, either one?
I'll just say I can compromise with you on disorder, as far as I'll go.
Yeah, okay. All right, well, you and I will work this out. Okay, well, we adjourn.